Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI CME podcast. And today we'll be talking about tardive dyskinesia and particularly updates in the current landscape of TD. And with me today is an NEI faculty member and good friend, Dr. Laxman Bahroo from Washington, D.C. Laxman, how are you today?
I am well. I hope everyone is well, too.
Yeah, I think you were busy today in the clinic. Am I right?
I was busy today in clinic.
Yeah, that's good. So you've got some experience fresh off the press here. Well, let's get started by, we've had two VMAT2 inhibitors, FDA approved since 2017, and I know you and I have been very involved with educating clinicians around TD, but we still seem to have a ways to go. And the big challenges, first of all, are recognizing and diagnosing TD and maybe differentiating it from other drug-induced movement disorders. So maybe you can just give us a quick description of what do we mean when we say TD or tardive dyskinesia?
Certainly. I think recognition is incredibly important. So if we look at tardive dyskinesia, this is actually a DSM-5 definition, and DSM definitions over the course of time have changed. I tend to think of tardive as a tardive syndrome. Rather than getting hung up on specific movements, whether they're choreiform or athetoid or dystonic, I tend to call it kind of tardive syndromes in that sense. Basically, the presence of abnormal movements in the setting of exposure to dopamine receptor blocking agents. So when we look at medications that block dopamine receptor blocking agents are going to be, for the most part, antipsychotics, but there are some older generation TCAs, as well as metoclopramide is going to be one, as well as phenothiazines, which are used for anti-nausea effect. Now that has become less and less common, but the first cases of TD that I saw were actually due to anti-nausea medications, interestingly enough. So we look for abnormal movements. Now, the old thought process was this was all orobuccolingual, and that's common, but not necessarily an exclusivity. If you don't have orobuccolingual, it cannot be tardive. If you have areas that are only orobuccolingual, that it must be tardive. So we tend to look for abnormal movements that have started after exposure to neuroleptics. In some cases, of course, it can occur in the withdrawal portion of it. So I have a gentleman today in clinic that I saw whose medications are being lowered, and he has abnormal movements. Now, I've followed him for medication-induced tremors for the longest time, but the abnormal movements have come up in the last 4 to 5 weeks, and they're withdrawal emergent movements. My feeling is they're just a little too dramatic. I'm giving him a few weeks to wear off the medications, but if they persist, then they are tardive. And so I think those are the one things we need to think about is onset after exposure to neuroleptics or after antipsychotics or dopamine receptor blocking agents. And can also occur when you are withdrawing off of the medication, especially if they persist 4 weeks, 8 weeks, or 12 weeks after the withdrawal of the dopamine receptor blocking agent.
Yeah, withdrawal dyskinesia, that's not necessarily TD, and that's usually self-limited after several weeks to a couple months.
4 to 12 weeks is the limit.
Got it. That's really helpful. Now, I know DSM-5 also has a sort of a time definition. I think it says that you have to be exposed for a certain amount of time. But, in my experience, people that are higher risk, I've seen it sooner, as soon as 4 to 6 weeks.
Absolutely. So the time limit comes and goes with different DSMs. In the past, DSMs had time limits. I want to say DSM-4 TR took away the time limits, which was good. 5 has brought in time limits, but changed the definition around a little bit more. Technically, it's about 3 months, less than 1 month or 1 month in the elderly, more potent D2 blocking agents, etc. I would say there's literature out there with individuals getting even a shorter exposure in the right individual, or should I say the wrong individual getting exposed to this medication. So keep an eye out. It's more the phenomenology of these movements in the setting of exposure than maybe a hard timeline. And maybe by the time they come to see a neurologist or you get a second opinion, or you start to look at it again, maybe that timeline meets itself. But maybe on the first trial, you may just raise your antenna about abnormal movements.
Yeah, that's the most important thing, I think. And, newer guidelines all say that we need to be, screening for these movements at every encounter on anybody taking a D2 blocking agent, such as an antipsychotic. And that's also a change from previous versions. That doesn't mean you have to do a formal rating scale like an Ames every single visit, but you need to at least look for it and ask for it, I would think.
Absolutely.
Okay, give us a sense of the latest prevalence estimates, and I know it's a little different with the first generation versus second generation antipsychotics.
So the prevalence, of course, continues to increase when we look for it, right? It's one of those things, if you look for it, you will find it type situation. The original numbers that came out were approximately 500,000, and this is probably about 5-6 years old data, and now the numbers have been revised up. And the prevalence really depends on us looking at it and putting a code down that says tardive dyskinesia. And if we do it, then it gets counted in the prevalence. So I think the numbers that we're looking at, the current numbers being talked about out there, are about 600,000. I suspect it's probably higher than that, because if you see a tardive patient and you didn't diagnose them and they genuinely have tardive, that it, by all practical purposes, that person doesn't get counted. If you look at the numbers with dopamine receptor blocking agents, the first generations, about a third of the individuals got TD. Now, that's interesting because we've had long-term data on those, much longer-term data. The second generations, when they came out, they were perceived to be safer from the studies that were done, but the study time periods were limited. So when you look at that data, and you look at that data over a long period of time, it's about 20% and down to about 7%. So the ranges are less than the first generations. But the irony is, I think the numbers are bigger because the second generation individuals can be, on major depressive disorder or bipolar disorder, schizoaffective disorders, and not to mention people have been on it for agitation in the setting of dementia, psychosis in the setting of dementia, and off-label uses. So the pie of the second generation is much bigger, even though the individual numbers are less.
Yeah, it's certainly true. A couple of them are even approved for irritability associated with autism, so we're using them at both ends of the age spectrum. And as you said, our indications and our usage has expanded greatly. So I completely agree with you. I think we're dealing with a hidden epidemic, if you will. I call it sometimes a ticking time bomb because I think the estimates are quite low, as you said. And there are estimates that the vast majority of people with TD are not even diagnosed or recognized or treated properly. So I think you're right that this is probably more common than we realize. Now, it's interesting to me, you said something, Laxman, that I find fascinating, and that is we expose a lot of people to these drugs, and yet not everybody gets TD. So there clearly must be some predisposition, maybe genetic or otherwise, that we just can't figure out yet.
Oh, definitely. There's some genetic thought process to it. If somebody within a first generation, second generation relative developed a medication-induced movement disorder, the risk of developing TD is higher. So if you have
you mean an acute drug-induced?
Acute. So if you look at the risk factors, one risk factor is age. Fair enough. Yeah. Everybody's aging in one direction. The second is, of course, duration of exposure. So for the most part, most individuals who start this class of medications, for the most part, continue them for the long duration. So those two are kind of going against you. The third one is, of course, in terms of if you have developmental delay issues, or autism that you brought up is interesting, or if you have individuals that are elderly that get exposed to it for the first time. So those spectrums are kind of interesting from age spectrums, developmental delay in the younger portion, older individuals with less dopamine reserve. And then you look at it and say, well, if you develop a medication-induced disorder, even in the acute setting of starting this, well, the risk of developing TD is higher. And if you had a family member who was exposed to DRBAs and developed it, well, your risk is higher.
I didn't know that. Thank you. That is very important. And also we throw mood disorders into that category. It seems that they are a little more vulnerable than psychotic disorders. So this is really helpful. I just want to be clear. So you're saying that if somebody develops an acute drug-induced movement disorder, and that can include drug-induced Parkinsonism, dystonia, or akathisia, you're saying that's telling me something about their dopamine system, maybe that they're vulnerable to later developing TD.
And I didn't realize this years ago either, but this is interesting because they're telling you that their basal ganglia is sensitive to D2 blockade.
I see. And so maybe we need to be very careful with our ongoing management of such a patient. Maybe use a lower potency drug or lower doses or something like that, minimize exposure as much as we can. Okay, that's really helpful. Now, obviously, the thinking about managing TD has evolved quite a bit over time. And I certainly remember I was medical director of a clozapine clinic in the early 2000s, and we used to put people on clozapine who had especially pretty bad TD, hoping it would help, and it sort of was plus minus. So where are we at now? What are the challenges, and how have they evolved over time?
So the main challenge, I think, is still diagnosis and recognition. So recognition, diagnosis, and then treatment.
Yeah,
we now have treatment options. Once upon a time, people used medications that avoided D2. I think that was a good strategy for when that was available. I think there are some strategies that I don't think should be done and probably never should have been done, but have been employed. And one of them is using anticholinergics. And if you look at the anticholinergics, the label specifically says that this is for patients with Parkinson's. And so there is a role, I hate to say it this way, but there's a role for anticholinergics, and that may be the drug-induced Parkinson's or the medication-induced tremor where you might use it. But you have to be careful.
Dystonia also.
Exactly. Dystonia also, the acute dystonic reaction. Yeah. But now here's an interesting thing. Those are the very same people that may be downstream sensitive to TD. So you may use anticholinergics on the front end. It may be helpful, but on the downstream, on the back end, not so good in that sense. Yeah. So anticholinergics got used and then kind of never let go.
Yeah, historically, many of us were trained to use anticholinergics, and the one most commonly it was benztropine. And there are some people who are recently trained who are telling me that they're still being told that's the right treatment. And of course, as you mentioned, in the package insert of benztropine specifically, it says it's not for TD. It can actually worsen TD, which is a problem.
And the thought process behind it is the balance in the basal ganglia. Basal ganglia has multiple neurotransmitter inputs, glutamate input, acetylcholine input, and dopaminergic input. And much of our discussion revolves around dopamine because, TD talks about dopamine and Parkinson's talks about dopamine. But when you add in DRBA, you're lowering the dopamine. You may have an reaction such as, tremor, or you may have a reaction, a dystonic reaction due to the mismatch. And that's the historical thought process. Adding anticholinergics there brings the levels in balance, hence that improves it. In TD, the issue is, while the dopamine level is normal, you have hyperactive receptors. And so the dopamine activity is higher, even though the amount of dopamine released is normal, but because you have hypersensitive receptors, dopaminergic activity is higher. Bringing down cholinergic activity by using an anticholinergic is the opposite of what you want to do. You don't want to do that. So that sets you up for a mismatch.
Yes. Wow, that's really helpful. It's like the exact opposite pathology. And of course, anticholinergics are the opposite mechanism of action of the VMAT2 inhibitors.
Exactly.
One other thing I want to talk about quickly with you, Laxman, before we get into treatment, is that, I used to think of TD as predominantly a movement disorder. And I think it's so much more than just movements. I think now we're getting a lot more tuned into the impact of these disorders, especially as we're using these medicines in higher functioning people, perhaps with mood disorders, for instance. So maybe you can talk a little bit about the impact of TD.
Oh, absolutely. I think the impact is very important, and I think we are all getting tuned into it. I agree. TD is a movement disorder, and my own evolution with TD has been very interesting. I once upon a time, I saw individuals with TD, and in my training, I was told, here, do the AIM scale on them. There's nothing we can really offer them, but hey, now you have an idea. Whenever the patient comes back, you can tell them if they're same, better, or worse with whatever changes. And we kind of used to offer our singular options at that point, and we'll talk a little bit more about that in the historical aspects of treatment options. And to be fair, we've gone from there to talking about, TD and following these individuals as we make management decisions. And now we're getting to talking about the impact of it because we realize not only does TD set of numbers, which is true, we use the objective aims to look at the movement, but really the impact of it makes a big difference. You may have higher functioning individuals with less TD than you might treat otherwise and say, they're incredibly bothered by it. Working in the DC area, we have lawyers who have bipolar disorder and have TD, and when they're dealing with, doing mediations or in courtrooms, they are incredibly bothered by their TD, and they feel that this is what people are focusing on instead of the argument or the conversation that they're having. And higher functioning individuals oftentimes will be bothered by much less TD than typical individuals would be. I think that's an important point. Certainly. Asking about the impact is very important, and there are actually studies that show this. Studies will actually show that individuals on dopamine receptor blocking agents treated and otherwise stable, individuals that do not have involuntary movements have a better kind of quality of life health scale issues than the individuals that do. The individuals that have TD do worse in terms of self-esteem. They do worse in terms of pain. They do worse in terms of functional scales of activities and holding down a job or being social. So TD really doesn't just impact, the mouth movements or the jaw movements, the leg movements,
Right.
but it impacts their ability to hold a job and communicate with family members and have social outings and self-esteem and kind of wellness issues that we kind of want people with mental health issues to have. But yet this becomes kind of an odd issue that actually hamstrings you from being more fulfilled in life.
That is really well said. And I like to say sometimes that TD is much more than just a cosmetic disorder. It's more than something that looks unusual or strange. It has far-reaching consequences for people, as you mentioned, socially, psychologically, functionally. I mean, this can even affect people's ability to breathe, to swallow, to do their chores, for instance. So I think we really need to be tuned in, and we really need to be assessing that impact because, as you mentioned, the DSM, the treatment guidelines for schizophrenia is where they talk about tardive dyskinesia. And they say that people with moderate to severe TD should be treated, but they say even those with mild TD, if they're having impact or distress, you might want to treat those. And so I always say don't make the decision for the patient by assuming, well, these are kind of mild movements. You really want to, inquire about that. And there are actually now some scales that have been developed by the two companies that make the VMAT2 inhibitors to really help you systematically assess the impact.
Yes, absolutely. And we want to talk about those scales about, you want to be able to ask somebody, what do you notice about their abnormal movements? Do you notice something? What do other people notice? What have other people said about this? And there's issues and one of the important issues that there's thoughts that, people look up stuff on the internet, they realize their TD is due to their medication. And the natural tendency for patients to do is that, well, this is due to my medications. I have to stop my medications or I have to reduce my dosage. Yeah. And that's absolutely the wrong thing to do because we know that'll actually put you into withdrawal. And I've had patients that have come in we've evaluated, talked about TD. They said, yeah, I know this is due to it. I stopped my medication for 5 days and my movements got worse. And I said, well, we ask you never to stop them without the guidance of your mental health professional or reduce the dosing. But this is why it can make it worse. And then nobody understands that portion of it. And suddenly stopping the medication, which you think is the culprit, is absolutely the wrong thing to do.
Yeah, that's well said. And something else we didn't mention, Laxman, is TD probably in the majority of cases is irreversible. And so we can't really cure it. We're just managing it, if you will.
Yep. And once upon a time, it was thought that, many people in the 70s, this is a self-limiting issue. It goes away. But the most recent studies that were done, the best studies were done out of Denmark, I want to say, where they followed, I think, almost 2,000 individuals for 2 years. And they followed these are individuals that had TD, whether they were exposed to GI medications or antipsychotics, but they were able to stop those medications and stay off of them. Now, that's a tall order to begin with. To follow about 1,000 or plus almost 2,000 patients with this for 2 years could only be done in a health system like Denmark. And they saw that 70+% of individuals still kept their abnormal movements. So TD is persistent.
It certainly is. Well, fortunately, as I mentioned, since 2017, we have 2 evidence-based and FDA-approved VMAT2 inhibitors for the treatment. Both of them are actually derivatives of tetrabenazine, an older medicine that was initially approved for Huntington's chorea. But of course, the problem with tetrabenazine is a very short half-life, so you have to give it 3 or 4 times a day. It has a sharp peak in the blood level, a high Cmax, and it goes up and down. And so, at those peaks, you get some significant side effects. It's very hard to tolerate. So maybe you could tell us about the 2 newer ones that are FDA approved and kind of help us understand the differences between the 2 and how we might think about choosing one over another.
You're absolutely right. They're both kind of newer molecules, and the tetrabenazine is the parent molecule. And you hit the nail on the head with the issues with tetrabenazine, and that became the limiting factor. Let's talk about valbenazine first. Valbenazine was the first approved medication. And what they did was basically by engineering tetrabenazine, what they did was they replaced a group by adding a valine group to it. And that made kind of 3 big changes to it. One, it took something that's a BID, TID, QID drug. And really, tetrabenazine was exactly that. We started with BID, TID, then went to QID. Because going up on the dose was only so much of an issue. You had to kind of spread it out at some point. With valbenazine, by changing that, it made it a 24-hour drug.
I see.
The second thing it did was it diversified the metabolism of it. Instead of just being dependent on CYP2D6, and then you have to worry whether this person had fast metabolizer or slow metabolizer, it diversified the metabolic chain to 3A4 and 2D6. So that was the second thing.
I see.
The third big thing it did was it changed the metabolite form of it. Valbenazine basically has plus dihydrotetrabenazine, whereas the other ones had plus alpha, plus beta, minus alpha, minus beta. So it had 4 enantiomers, whereas this had 1. Right. And so now you have plus alpha, which is actually the most potent VMAT2 inhibitor as well. So you have valbenazine and its main metabolite, both are, good VMAT2 inhibitors in that sense. So that's interesting from that perspective. And what that did was basically it allowed us to be able to use the medication once a day. And not only did they do that, but they also did a study that looked at not only the benefit in terms of the AIM score, but also the fact that there was psychiatric stability in individuals. So they had to be psychiatrically stable to begin with. And they stayed stable during the study portion of it, which was a concern because if you look at the tetrabenazine label, and if you look at it kind of overview, you get a little concerned because of the suicide risk. Well, keep in mind that suicide risk was the Huntington's population, which is prone to impulsivity and depression, but it gave people pause for it. And I remember the time period of the tetrabenazine era when I had TD patients, and it was very difficult to surmount that boxed warning because on one hand, the evidence was less, and on the other hand, you had the boxed warning, and they kind of played against you in terms of trying to manage it. Here, the issue was now there's specific data showing benefit and as well as safety in terms of psychiatric stability. Now,
that's really well said, because I think again this may be a peak effect. It's sort of like if you deplete dopamine or decrease the amount of dopamine released too much, that's going to cause depression. Dopamine's a pleasure chemical, and so what's interesting is these 2 new ones in the tardive dyskinesia studies. There was no depression or suicidality seen, and so while they now both carry the bolded box warning, that's specific to Huntington's patients because both of them have now been approved for Huntington, so you inherit that. But I think your point is very well taken. Both of these were really monitored for psychiatric stability. And what's interesting is that the VMAT2 inhibitors were simply added to whatever regimen the patients were already taking. So there's no need now to play around with the baseline antipsychotic, lower the dose or switch it or whatever. And a lot of times, Laxman, it takes a lot of trial and error to find the right antipsychotic, the right dose to treat the psychiatric condition. And so these can be life-saving medicines. Yeah.
Absolutely, very much so. And I remember, again, that era before VMAT2 inhibitors were used, I would tell people, can you lower the dose? And the answer was no. And I'll be honest with you, there's no evidence to show that lowering the dose helps. In fact, the AAN guidelines looked at it and said the options we offered people were useless options. Lower the dose, doesn't work. Can you change to a different D2 blocking agent? No, that doesn't help. Can you remove it? That's not possible. I'm like, these are terrible options. And the data shows that even if you stop it from the Danish study, that people will persist. Now, deutetrabenazine is interesting. Deutetrabenazine is also a fascinating pharmacology, where this is fascinating from the valbenazine portion. Deutetrabenazine deuterates it. So it replaces the 2 normal hydrogens, takes them away, and adds deuterated hydrogens. Now, that strengthens the bond. As that bond is strengthened, the metabolism is still done through the CYP2D6. It changes it from a QID drug to a BID drug. And now, of course, we have the extended release of deutetrabenazine as well. And that's its own neat set of pharmacokinetics, how that works. And basically what happens is it changes the pharmacokinetics to BID dosing for the standard deutetrabenazine. And what you basically are doing is reducing the peak effect. As you mentioned, the peak effect of tetrabenazine was the problematic issue. So you go from a peak to a more blunted peak, but a longer duration of response. And then you're still 2D6 based. And in other ways, the metabolism breakdown is also plus minus alpha and beta. So you keep all of those, but you've gotten around the peak and you've gotten it to a BID dosing. And I think from a pharmacological point of view, I'm still fascinated how we've come up with medications and then tweaked and modified them over the years.
Oh, I agree. It's very elegant science and chemistry here, but just let me review a little bit and be clear for our audience that tetrabenazine has 4 active metabolites. There's plus alpha plus beta minus alpha minus beta. And it turns out that the plus alpha and plus beta are the ones that carry the VMAT2 inhibition. As you mentioned, plus alpha, which is a valbenazine, has the highest affinity. And it's interesting that I would have thought, Laxman, that you would break down tetrabenazine equally into 25% of each of these metabolites. Well, it turns out it doesn't work that way.
No.
That tetrabenazine and deutetrabenazine, which is simply deuterated tetrabenazine, are predominantly plus beta. Whereas what's really elegant about valbenazine is they isolated the plus alpha and, as you said, retro-engineered it, if you will, to make it last longer. And so these are actually two different chemicals in a way. They're two different drugs.
They are.
And what's fascinating about that is if somebody doesn't respond as well to one or doesn't tolerate one, you really should try the other. You shouldn't give up on the mechanism of VMAT2. Would you agree?
Absolutely. And I think that's very important. And I would say the opposite is true. Should somebody have benefit with one medication but have a side effect or so, that it's important to say, let's try the other one. Maybe you're more sensitive to one issue or another. And because of the metabolite is different, yes. And they both have their own merits of their data. They've done studies with TD patients, and they've shown stability from a psychiatric point of view while adding the dosing in to be able to fine-tune and reduce the AIM score in both of them. So no, I agree. If one does not like one or has an issue with one, we always look at the other one and say, let's consider trying that out.
Yeah. Now, I want to be very clear that both of them have very impressive efficacy data, and they both have really surprisingly good tolerability. Some of the best tolerability, I've been doing clinical trials for 30 years. This is some of the best tolerability that I've seen, especially when you consider they're both coming from a drug in tetrabenazine that has a lot of safety and tolerability issues. So these manipulations have made a huge difference in terms of smoothing out the PK curve. And it's interesting that deuteration is being looked at for other medicines. And essentially, if you take a short-acting drug and you deuterate it, as you said, it's almost like making it an extended release. Yeah. It sort of slows down the metabolism. You decrease that Cmax, maybe the same area under the curve, but you extend the duration. And I want to be clear that deutetrabenazine, as you said, is now an XR version, which is once a day. And also, it removed the requirement to be taken with food, which the old version, the immediate release version, had to be taken with food. So, there used to be a very big convenience advantage with valbenazine, and I would say that gap has been narrowed, although valbenazine only has 3 dose levels, whereas deutetrabenazine has several, a range. The effective range has been from 24 up to 48 milligrams. And in some ways, that may be a good thing for some patients because it allows you to really precisely dial in and get the best balance of efficacy and safety, although unfortunately, both of these VMAT2 inhibitors, when we look at prescribing data, are a little bit underdosed. We think that people are a little afraid of them.
Right. And I think from a psychiatry point of view, these are still newer classes of medications. The VMAT2 is a newish class, 2017-ish, and they've been available from the neurology side since 2010, with tetrabenazine being the original molecule. And even then, tetrabenazine does not have a huge group of individuals prescribing it when it came out, because it came out only for HD chorea, so it was a niche medication. But the familiarity with VMAT2s is interesting. And I think part of the challenge with the VMAT2s is I think people start them, patients get benefit, and they're like, well, this is good. Let's not advance further. And I think goal setting with TD is something that's different because keep in mind, it wasn't that long ago that TD was treated. We didn't treat TD until pre-2017 that much. We couldn't definitely treat it. So now that we're evolving in the process of, diagnosing it and learning about the impact of it and treating it, and what is that goal setting? And my philosophy is I start treatment, we look at you, we look at the AIM score, I compare it, and I say, you're better. And my question is, do you want to stay here or do you not? And that's a little bit of shared decision making between the provider and the patient. And I kind of put the onus on the patient and say, do you want to try to see if you can go up? And the patient says, let's try it. I said, what's the worst that's going to happen? You don't like it? You feel it's too much, or you feel like you develop some side effect with it? We back down the dosage down. Yeah. So it's almost behooves you to try it. And maybe the patients are a little on the cautious side of the new medication. We're cautious, and it's the cautiousness of both of us that kind of leads to underdosing. Yes.
Yeah, I'll be honest. I'm a little bit more of a cowboy than you are. I'm certainly using shared decision-making, but I'm a little greedy, Laxman. I always nudge up a little higher. I want to see how good can this thing get to some degree. And the dose-related side effects with both of these drugs appear to be to some degree sedation and Parkinsonism, perhaps, and a few others. But they tend to be dose-related, so you can usually manage them through lowering the dose.
Yes.
But as far as really serious problems, serious ways to get into trouble, there aren't a lot with these drugs.
No. And the interesting thing is they both have long-term data. Valbenazine has 2-year data, and Connect 4 is their trial, and deutetrabenazine has 3-year data. And it's impressive when you look at the data and you're like, what am I seeing? What am I not seeing? You're seeing typical things that people have issues with. I got some infection, I got this, I got that. But the interesting thing is about those studies is patients often will switch doses up and down. And I think that's reality. In a controlled trial, you have to be on either one of these doses. You must be on a fixed dose, or you get to fine-tune your dosing up to a certain point, and then you must maintain it. And that's important for data. I completely understand that. The open label extensions are nice, but again, people are kind of fixed into that data. But in those longer term trials, people move their doses up and down. And one, you get to see sustained benefit. I think that's amazing. I think 2, you get to see tolerability. So you get efficacy and tolerability in long-term data. That's incredibly helpful. And I think you're right. The biggest issue that I would foresee is that people with exposure to dopamine receptor blocking agents plus exposure to VMAT2s, which are reducing the dopaminergic activity, you end up with tremor or Parkinsonian symptoms. Again, backing down the dose is the absolute right strategy.
That's a really important point you're making. I always joke, you don't want to set it and forget it, so to speak, set the dose. I think this is one of the most important pearls maybe we can give the audience is in the long-term management with a VMAT2 inhibitor, you really need to consider adjusting the dose as needed for, again, both efficacy or tolerability. And again, what's nice is we do have different dosing options here with these drugs. And perhaps people will want to be cautious early on, but maybe as you go on, maybe you can try to push the dose up and try to get even more. One of the things I'm fascinated by when I look at the efficacy of these drugs is you get a relatively rapid improvement over the first few weeks, but there's a suggestion of continued further improvement, more gradual improvement over time. Now, I don't know that that is continuing over years, but it looks like over months. So sometimes in kind of managing expectations, you might want to tell the patient, it's going to usually work when it works. In the first few weeks, you'll notice some definite improvement, but you may notice some gradual further improvement over time, so stick with it.
Yeah, no, I think that's very true. I've seen that personally where I've seen individuals that start off at at week 2, week 3, they'll get benefit. And then, as I said, sometimes it's a little bit of, do you want to stay on this dose or do you want to go up? And sometimes people say, let me stay on this dose. And the data shows benefit across the board. I think both long-term studies show, even though the patient switched around, that there was some gradual improvement and reduction in their AIM score. It's kind of reached an asymptotic portion of it where it dropped and kind of stabilized, but it continued to drop. And I don't know the mechanism behind it. I don't think it's just the VMAT2 portion of it. I think probably there's downstream changes that occur with it.
I'm sure you're right. Yes, I'm sure you're right. Well, the brain tends to continuously and gradually adapt, has been my experience, to whatever we do to it.
Yeah.
So, we certainly have now 2 effective options that have a lot of differences. The first difference we mentioned is they're actually 2 different metabolites, 2 different chemicals, if you will, of tetrabenazine. They also have different dosing strategies, and there's some other different kind of practical considerations around different kinds of warnings. Both of them have mention of the QT prolongation, which is a big problem with tetrabenazine. But again, by smoothing out the peak levels, it's less of an issue with these drugs, and neither one of them requires an EKG to be done at baseline, which is nice.
Yes, that is very nice. Unless, of course, we find somebody's already on a QT prolonging agent or has been told that they have prolonged QT, in which case, if you worry about that, then you're better off being safe in that sense. But I completely agree.
Yeah, and if you're taking a drug that prolongs QT interval, you might want to assess that. But you know what I always joke? Everybody deserves at least one EKG in their life, Laxman. So it's good to have a baseline EKG in case, God forbid, later on you have chest pain or something.
Absolutely.
Yeah. What's interesting, too, we talked about the really surprisingly good shorter-term tolerability in the initial 12-week studies. But just because a drug looks safe or well tolerated over 12 weeks doesn't mean if you keep taking it over a year or 2 or 3 years, that something will pop up.
Right.
Maybe a cardiac issue or a liver issue. And as you mentioned, both of these drugs have now been studied for a couple of years and no new safety findings have popped up.
Correct. And I think that gives you a certain amount of comfort, especially if you're dealing with a newer class of medications for a condition that's kind of just lingered until recently. And I think shorter term studies are great. Those placebo-controlled trials are good. Open label extensions going out to a year are great. But when you look at that long-term data, that's good. And ultimately, the most long-term data will be our patients that have been on it. And my experience has been, as I'm sure it has yours, is patients that started back in 2017, 18 with these medications, most of them are still on these medications. And yeah, we do have to adjust the dosage for some of them. Maybe we adjust the dosage because the underlying, antipsychotic has been adjusted or they've aged and other things need to be done. But we keep them on it, and people have been on it for now going on 5, 6+ years.
That is certainly true. And that's really encouraging because unfortunately in these studies, when the medicine was stopped, did appear that the symptoms did come back. So again, we're not curing this for most patients. This is something that needs to be a chronic management, chronic treatment, if you will.
Right.
Something else that we should probably talk about is now, as let's say movements are getting better, and we're starting to look into the longer-term management, we now have a situation where people may have really limited their life. They've really made significant accommodations to the TD, and now maybe we need to help support them to gradually reemerge, if you will, and start partaking more of life socially, work, school, recreationally, and others.
Oh, absolutely. Absolutely. That becomes the second portion after their TD movements have improved. I had a patient she was a nurse, and she told me, she said, she's got diagnosed with bipolar, fresh out of nursing school, and got put on medication, worked as a nurse for a good decade or so, developed tardive, and then kind of went into the shadows. I mean, this was a high-functioning individual and showed up about 7-8 years after TD. Now she's in her, close to her mid-40s at this point. And she told me, she said, I'm afraid my movements are TD. And I said, well, I'll be honest with you. I know they're TD. You're absolutely correct on this. And she came to me as a second opinion or a third opinion. And she said, my fear is I don't know what to do about this. And we talked about, adding in VMAT2 inhibitors. And we talked about that. And then that discussion kind of spurred her to say, let me talk to my psychiatrist about it. And she went to her mental health professional who said, I'm totally supportive of this. That's why I sent you to a neurologist for the second opinion. And we started her on medication. And one of the most interesting things was this gets, more often than not, we get these phone calls that are not necessarily the best phone calls. People are not doing well. That's why they're calling you.
Right.
So about 4 weeks after we started her on a VMAT2, she calls the office and said, I need to speak with you before the holidays. And I'm like, oh, here we go. Some problem has befallen. This is the week before something's going on. So I pick up the phone. I'm a little hesitant, and I'm talking to her, and she's like, I just want to let you know, I'm doing great. And I was like, okay, wait for the other shoe to drop. No, I'm doing great. Exactly. And she said, my neighbors noticed last week that I'm doing much better. I'm not having all these movements that I would have. They were very worried what was causing those movements. And they've been very worried for me for months. And they noticed I wasn't having any. So they actually told me that, and that made me feel better. And so last week I went to my psychiatrist for the appointment, and they said I should notify you. And I said, well, I appreciate that. Okay. You made my holiday season. And I said, I'm going to see you right at the beginning of January. And so it's great. You don't get those kind of phone calls. And it's nice to have those phone calls.
No, I know exactly what you mean. It can be life-changing for these folks as they start to re-engage with life. I've come up with, not a mnemonic, but I've come up with a system I call the 4 R's, Laxman, to evaluate the various aspects of somebody's life and the impact. And my 4 R's are, you inquire about the patient's roles, their responsibilities, their relationships, and what they do for recreation, for fun. So I just find that really with any condition that I'm dealing with, I use that to kind of inquire and establish a baseline and some targets to monitor. So for instance, the nurse is a great example. So is she now thinking about going back to work? as her role? Is she now, let's say, going to join the family for the holidays, which would be her relationships? And are there hobbies such as, did she withdraw from her friends and stop having lunch with her friends or playing cards with her friends or going shopping and out in public? And now she's able to do those things. So I think it's important to establish very specific targets that are individualized to each patient and not just say, are you engaging in activities,
Oh, no, I completely agree with you. And I think the last, I've since lost her to follow up, but we left things open-ended with her, saying if you have an issue, come in. And more than about 60% of these individuals go back and they say, thank you for taking care of this. I'll come back to you if there's an issue. If not, I'm happy to continue the treatment with your mental health professional. And I'm totally fine with that.
Yes.
Because that's one more appointment that they have to come to, and maybe I'm not the easiest person to get to because of distance traveled. So last I heard that she was actually, reconnected with her brother with whom she had a falling out. I don't know what the falling out was due to, so that was one. She actually was thinking of going back to working, not necessarily as a nurse, but working in mental health. And she said, I have a different perspective on this, having suffered from bipolar disorder and having tardive, that I think I can actually help other patients who have similar situations. And I was like, this is the perfect way for you to give back based on your life experience. But that's where our conversation ended.
No, absolutely. You're just making me think of something else I've heard from patients, which is, if you have a mental illness, people can't necessarily tell just by looking at you. But when you develop tardive dyskinesia, they know something is off, odd, weird, whatever it is. It stigmatizes you in a different way. And so I think that this is another reason why we really need to think about examining the impact and then aggressively treating this condition. But I have a question for you here. Sure. I have sometimes heard a little pushback from my fellow clinicians who say, well, I don't think my patient's going to want to take another medicine here. How do I get them to do that? So what kinds of advice do you have for having those kind of conversations?
And I think that's a ubiquitous problem. No patient wants to take one more medication, where the phobia is that it's one more pill and then I'll have a side effect from that pill, and then that will result in another medication. So this becomes an interminable cycle in medicine, even though we were all taught in medical school, don't do that. And so the resistance, I think, comes from two people. One is that they view TD as a side effect of a medication. And so now I'm treating a side effect of a medication, and that's going to have its own side effects, and you're going to put me on more meds.
That's right.
And I kind of address it by saying this is due to the long-term exposure of this medication. You cannot go off of your said antipsychotic. You cannot. If you could have, that would have been done already, but you needed to maintain mental health. Now, the question is, TD is here. It's your lifelong companion at this point. Mm-hmm. And the key is, do you want to manage it or not manage it? And there, actually, I think impact comes out in a bigger way, because if we just look at numbers, that's great for us to be able to trend improvement or worsening, et cetera. But it's not great for the patient, because they're not looking and say, well, my AIM score just reached a 7, so I'm in here in our office talking about treatment. Or it's down to a 4, so do you think I still need medication? We talk about, common things, basic things. How difficult is it for you to chew your food because the mouth movements are there? How many times do you bite your tongue? How difficult is it for you to drive because of the eye movements and the head movements that are affecting it? Do you find that you don't have companions at work to engage with you after work because, they look at you like, oh, let's not invite him because he does these things. So, if those movements are bothering you or they're causing you discomfort, like you go to the dentist 4 times a year for jaw pain that nobody can find an answer for, or you've gone to the orthopedist for knee pain and foot issues or falls, these are all part and parcel of your TD. By managing this, my goal is to lessen this. And then people are a lot more willing to listen to that.
No, I agree. This is part of shared decision-making, which is to understand what the patient's goals are, what are the motivators for them, and to say, it could be that using this treatment could address those or help you reach your goals. Yep. I also think it's very important not to feel like you have to close the deal with the first conversation. I feel like we're sometimes starting a conversation and starting a process that may lead to acceptance, but you don't have to feel like it has to happen right away. Sometimes what I find is, as you talk about these and bring the movements to the patient's attention, they will come back and say, I never really noticed how this is affecting me, or I never really noticed this until I discussed it with my partner or my friend who said, yeah, you're really having these movements and this kind of thing. And that brings up another point we should mention, and that's the importance of involving others in the patient's life, whether this is a partner, a friend, a coworker, whoever is important in their life and maybe would be helpful in this process. And that can also be helpful too because, tardive dyskinesia does not have a sensory component generally. I mean, people will feel the complications of the TD, so they may not notice the movements as much as someone else might.
No, absolutely. Absolutely. And many times, if I have individuals, sometimes they can't tell me the issue of what's bothering them about their TD. And if there's someone else in the room that's accompanying them and say, well, what do you notice? What have you noticed? And if they're a family member, they're ready to point out that, the meals are a mess because of this, or, the challenges are of getting them to not fall because of the tardive movements or other things. And that helps me make that. And sometimes that caregiver or the family member kind of circles back and says, we should really look at this. So my goal at the first visit for abnormal movements is to confirm or not if there's TD or not. And then if it is TD, which is the most common, is I give them a booklet on TD and I give them the online resources. Go look at this. Really helpful. Go look at this, examine how it impacts you, come back and see me in about 2 to 4 weeks. Now, for me, the first appointment on TD or any new movement disorder is in person, because for me, that's the mainstay of being able to see the movement disorder. Well, the second appointment for convenience does not have to be. I can do a virtual appointment. We've already done an AIM score. We've already established the diagnosis. Second appointment is more conversational. I gave you literature. What did you think about it? What did family members say about the impact? What did you feel after you were more in tune with this? What did your mental health professional say? Let's bring that in about 4 weeks, connect that and say, do we want to move forward? And if so, how?
Yeah, well said. I'm a big advocate of providing resources. And this is probably part of the collaborative process, the shared decision-making process, is to help people to have more knowledge, more tools at their disposal. There's much more than just throwing pills at people. That's what I sometimes say. And Laxman, I'm not sure if you're familiar with a national organization. It's actually based near me in Tampa, Florida. I live in Sarasota, and it's called NO-TD, National Organization for Tardive Dyskinesia. And I'm going to give out their website because I always recommend this, and it is tdhelp.org. tdhelp.org, National Organization for Tardive Dyskinesia, which is NO-TD, which I love, is a great mnemonic. So that's one place that you can find resources and help, and I highly recommend that. As we're talking also about this, it's very important to explain to the patient what to expect and what we can do about things as we go forward in the long-term management. I always say people don't like surprises, so we might talk about some of the possible side effects, although in general these are well-tolerated medicines and often can be managed, as we said, by adjusting the dose. But we also talked about what to expect as far as the pattern of improvement, the pace of improvement, the timing of improvement. But also we probably need to talk about the fact that this is probably for most people, a chronic condition, and you think of managing it like you would high blood pressure or diabetes. We don't cure it, so it's chronic disease management. Would you agree?
I agree. It is a chronic condition. It requires chronic treatment. And I think I set that expectation up front. And many times individuals have had TD for quite some time. And it would be intuitive that it's a chronic condition, but it's important for me to say, like any other condition that you have, whether it's a mental health condition or another portion of it, this is a chronic condition. It requires daily management. So I set the expectation that the goal isn't to adjust your antipsychotic medication. The goal is to manage this with the medication, to treat it from here on outwards, and then might be ups and downs and fine-tuning it. I do set the expectations of sedation, maybe a possible side effect up front, because people may be on other sedating medications, and this may really bother them.
That's a good point.
But I talk about the fact that it's limiting. We can lower the dosage, even though with valbenazine, the sedation wasn't shown to be dose-related. I do point out that we will stay at that lower dosage for a longer period of time. If there's akathisia that develops, we can talk about it. If there's tremor that develops, we can lower the dosing if we need to. So there's options and ways to manage it should we run into those issues. But I also point out that this is something that requires them to see someone for their TD, whether it's they want to see the mental health professional for both things, or they want to see me for this and keep their psychiatrist or mental health professional for the other issues, that's fine too. And then if they do, I see them maybe twice a year to double check with them to make sure things are okay.
Yeah. You brought up a couple of other things. I've actually heard of situations where somebody's had this TD for a long time and now all of a sudden it's getting better. And I've had people kind of living in a little bit of fear that it's going to come back. And I think we can turn to the clinical trial data maybe and say, look, the clinical trials show if you continue to take the medicine, it does not come back, that they continue to work.
Yeah, they continue to work.
And then, as you know, it's very hard to take a medication chronically for, say, the rest of your life. And so I almost expect that people are going to try to come off the medicine, or maybe accidentally or on purpose. And what I often do is I will say to them, listen, I know how hard it is to take meds every day. And I know that when you're feeling better, that maybe there'll be a temptation to stop, or maybe you'll forget to take it and get off it. Please just let me know as soon as possible, and let's get you back on it as soon as we can and try to get it back under control. But sometimes people want to test the water and see what happens.
And completely normal. It's a very human thing to do. And I actually take a slightly different approach towards this. And I think that's an excellent point because people are tempted to do this. So I tell them exactly the same thing. I said, and people ask you this about, in my opinion, probably around week 16 to week 24 of being on medication. And they'll say, I'm better. Do I still need to do the medication? And my first answer is, you're better because you're on treatment for it. You're better because you are on this treatment. So go ahead and continue it. This is why. And I'll point out to the trials data. And if you look at trials data when the trials ended, the TD numbers, the AIM scores came right back. And I'll say, the underlying factors that cause you to have TD have not changed. This is managing it, but not curing it. And I want you to emphasize that. At the same time, I do tell them that there's a gradual improvement that we see in the data over years of exposure. But at the same time, it's not cure. It is basically management. And if you stop it, the movements will come back. Now, the flip side is, despite all that information that I give them, people still want to try it. And again, that I think it's human curiosity in that sense.
Human nature, yeah.
So what I tell them is you want to lower it, let's do it in a reasonable manner. Let's lower the dose 1 or 2 steps. So
I see.
I'll tell them,
reasonable.
So let's say if you're on valbenazine, I'll lower the dosage by 1 step for about a week or so.
Right.
If you're on deutetrabenazine, I'll say, okay, typically you might be in a combination of 2 different capsules or 2 different tablets of dosing. So go ahead and lower by 1 and then do that. And if they're on the XR formulation, they might be on a combination of of pills. So go ahead and lower by 1. And then on the other hand, same thing with the twice a day, just go ahead and drop out the dosing of one of them. If you're taking 24, just take 12, see how you do. Give yourself a couple of days. Majority of the patients will go back.
Yeah, I'm sure they'll see the movements come back. So that's interesting. That's an interesting trial. We know adherence is not good with any chronic medical condition. So I don't expect this to be any different. So I'm very realistic with people. Now, you brought up something else that we've got to talk about, and that is the combination of medications people are taking, the so-called concomitant medications. And I think, again, we can turn to the clinical trials and the data in that VMAT2 inhibitors were added to whatever they were taking, and that included a lot of different medicines for medical conditions, blood pressure medicines, lipid medicines, and so on. And the tolerability was, again, surprisingly good. So I think we can reassure a patient who is worried about adding another medicine and drug-drug interactions that it appears it's relatively safe to do here. Now, there is one exception, and that is our friends, the anticholinergics.
Right.
Including benztropine. Right. And so here, I think we need to have a strategy for how to handle that. Do you have any thoughts about how to handle somebody who's on an anticholinergic, and now I want to certainly add a VMAT2 inhibitor and hopefully eventually stop the anticholinergic?
I'm going to give you 2 ways to manage it. I'm going to give you the study way to manage it, and I'm going to give you what I do, because there are 2 different ones.
Yes.
So in the studies, patients came in with their medications, their antipsychotics, their anxiolytics, their antidepressants, a combination of medications. Remember, because people had bipolar disorder, major depression, schizophrenia, schizoaffective. So they came in with their psychotropic medications, plus, as you mentioned, their other medications for chronic health conditions. And a chunk of those patients, I want to say somewhere between a quarter to a third of the patients, were on anticholinergics. And they kept those because for the sake of the trial, and they added this on top. So the first way is, you have TD, you have somebody on a stable set of medications, You start them to manage with the VMAT2s, and you start and reduce the VMAT, use the VMAT2 to reduce their tardive movements. You can address the anticholinergics on the back end if you want to. That's fine. Yes. But remember that anticholinergic labels all say that it can contribute to TD and possibly worsen their TD. And that's on the label. But, that's an important point to remember. Now, what I do in my clinic is I see this individual, and as we said, the first visit isn't always about starting somebody on medication. The first visit is a conversation. And so I look at it and I say, well, you're on your current antipsychotic regimen, your anxiolytic, antidepressant, and all the other medications for blood pressure, statins, etc. I said, why are you on this particular anticholinergic? And the answer is, well, that's been with me for months, years.
Yeah, it's often long-term. Yeah.
And it's long-term. And if they can't answer a message, I'll say this. I will do a slow taper, and I'll see you back in 4 to 6 weeks. And it's a perfect time to do a taper. And I'll say there's one reason possibly that you're on it, which is either you had a dystonic reaction early on, and if people can't tell me that, that's fine. Or you had tremor at some point and say, I'm not sure about that either. Let's do a taper. The rule is the longer you've been on it, the slower the taper. So I do a 2-week, 4-week, 6-week taper. And I do a taper with one instruction. Yes. If you see a dystonic reaction come out, which is unusual because they're usually acute, but if you see tremor come out, stop that dose at that point. Don't taper any further and notify me. And I see them I bookend my visit on the back end of that. So I see them at that point, and then they'll say, hey, I didn't need it. I stopped it fully, or I stopped it and I'm down on the last dose. And I'm like, great. Yes. So I've kind of cleaned them out, and then now we can begin a conversation on adding a VMAT2 at that point.
Oh, I see. So you taper gradually the anticholinergic first and then add. Now, I thought you were going to talk about a cross taper where as you're introducing the VMAT, you come down. But that makes perfect sense what you're saying, because it could be that the TD will get a little bit better anyway. And you're also very generous, Laxman. You're assuming people are starting the anticholinergic appropriately for dystonia or drug-induced Parkinsonism. But unfortunately, they get started for movements that are not responsive to anticholinergics, such as akathisia or TD. So I think it's very reasonable to taper them off and see what you have and see if something emerges.
And my philosophy is anticholinergics are quite sedating medications. Maybe they've tolerated to the sedation, maybe not. So I'm of the opinion, if I can clean you out a little bit from this medication, maybe you don't have as many of the issues on the back end with regards to sedation.
Interesting.
So
that's very interesting.
That's my philosophy. And since I have time to do it in clinic, which they didn't have time in trials to do it, it's easier for me to kind of do the second visit and say, now let's make some decisions. And maybe by the third visit, we've started treatment for it, or they're kind of deciding to do the weight approach, which is fine. But then I'll tell them, you call me back when you're ready to start.
This is fascinating because you're using good psychopharmacology principles, which are do one thing at a time, rather than maybe overlapping and adjusting both doses at the same time. But you're right. In the clinical trials, we just layered it on top of the anticholinergic, and then later, I guess you would taper it. So I think these are all reasonable strategies potentially, and we have to individualize and do what makes the most sense for the particular patient. But I like the idea of your talking about sedation, because you're absolutely right that anticholinergics can be quite sedating, and that does tend to be the most common side effect, and it is dose-related with the VMAT2s, and so that might limit our dose of the VMAT2 because of that. We also know there are serious consequences of long-term use of anticholinergics. It includes dementia, delirium, constipation, urinary retention, which are all bad things as we age, of course.
Absolutely.
Well, I think the other thing that I like to do is I like to have them, I call it the shopping bag trick, Laxman. I have them fill up a shopping bag with every pill bottle in the house. I want to know everything you're taking, both prescription and over the counter. And I have been shocked sometimes what people are taking that I wasn't aware of. And, you can clean things up to some degree and minimize either pharmacokinetic or pharmacodynamic drug-drug interactions. So that's another trick. We're getting close to thank you. We're getting close to the end of our time. I have these Cutlerisms. They're called, friends of mine call them Cutlerisms. But we're getting close to the end of our time. I think maybe we should talk a little bit about any ongoing research or other things that are going on in the research of tardive dyskinesia, either the understanding of it or the treatment of it.
So the understanding is actually interesting. Our initial thought process, of course, was that these are hypersensitized D2 receptors. And while that's true because, increasing the dopamine receptor blocking agents suppresses TD temporarily, only to reemerge worse. and removing the DRBAs or reducing the DRBAs temporarily worsens it. So that fits with the fluctuations of it from that understanding. But that probably isn't the full story. There's probably downstream changes, because if it got better with withdrawal in the short term, got worse than better, that would go away completely. So there's some downstream changes that we have to look at. There's probably some remodeling that happens and some downstream changes that have happened. So we have to look at that. I'm not sure we've done that. And I don't know when we will get to that point, but I think with the new imaging scans that show activity in the brain, I think it's very interesting to be able to look at that from that perspective. So that helps us understand the pathophysiology behind TD. It's important that we have the ability to manage the symptoms, but deeper understanding would help us. Of course, some of the newer antipsychotics, of course, are not having any dopaminergic activity. And I think that'll be interesting from a TD perspective point of view of where that changes and how that changes TD.
Well, you're talking about the muscarinic antipsychotics. You're right. That's a whole new thing. Yeah,
exactly.
They don't seem to be associated with movements. Yeah,
exactly. And they shouldn't be for all practical purposes, because they don't work on the dopaminergic system. So, and I'm not a psychiatrist and I can't talk about how effective they are, where you would use them. But I think that's interesting from a psychiatric point of view.
Data is extremely effective. They probably do indirectly affect the dopamine system, but only in psychiatric parts of the brain, not in the motor parts of the brain, interestingly. So that's a whole other episode here.
Yeah. No, we often joke about how D2 is a bystander in that sense.
That's
the goal is the mesolimbic system, but we've ended up in the striatonigral system.
Yes, that's right.
And then the third most interesting thing I thought was they're actually looking at TMS to see if that changes tardive. I think that's very interesting. And a variation, which is, TCDS, which is transcranial direct stimulation, and see if that helps. And I think that's a level of interventional neurostimulation that, we've had on the movement disorder side, psychiatry has with TMS. And I think that interventional approaches are going to be very interesting for patients, whether that's for individuals who may not benefit from VMAT2s or couldn't tolerate it or need this as an adjunct therapy. That opens up a whole set of opportunities that we've never talked about and maybe not thought about even.
You're right. And also, botulinum toxin has been used for focal kinds of drug-induced movements as well. There actually is quite a bit of research being done on the neuropathology. There have been some advances in the genetics and the neuroimaging, and I completely agree with you that I think our current theory here is inadequate, because we talk about chronic D2 receptor blockade, and of course the brain will upregulate, make either more or more sensitive receptors, but you know what? That happens with everybody, Laxman, and not everybody gets TD.
I agree.
And also, if that was the case, when you stop the antipsychotic, your receptors are quite plastic. They will go back to the way they were, but it doesn't go away for people, as we talked about. So I agree with you that probably starts a cascade that in certain vulnerable individuals, maybe genetically or otherwise, leads to some downstream effects that unfortunately could be irreversible. Perhaps it's neurotoxicity or some other adaptation.
Yeah.
So we do have a lot more to learn. We need more treatment approaches always. I would say just a couple of quick things about the two current VMAT2 inhibitors we had. Of course, one of the big developments you mentioned is the extended release preparation of deutetrabenazine, which makes it once a day, simplifies the number of pills and the titration, although it's not, there are certain doses that do require 2 different pill sizes still, even though it's just once a day without food. And then with the valbenazine, recently valbenazine, which was only approved for tardive dyskinesia, has now been approved for Huntington's chorea. So both of these drugs are approved for both TD and Huntington's. And I know there are ongoing studies with both of these medications to look at various other ways of using them, various other indications, such as tic disorders and things like that.
Yes.
So it's an exciting time for us. And it's certainly wonderful having practiced now for over 30 years. The bulk of my career, I had nothing to treat TT. And to actually have these really effective, safe and well-tolerated medicines is just a boon to our patients. So Laxman, we have reached the end of our time. It's been wonderful, as always, speaking with you. And do you have any final thoughts or comments for our audience?
No, I think you gave a beautiful summary on this and how things have changed, and in some ways, in the grand scheme of things, on a dime, right? And in 2015, the American Academy came out with a statement looking at the practice parameter on TD and found that nothing was level A. And a few years later, it suddenly had 2 level A evidence medications, both VMAT2s. And I agree. More research is needed, and we have options. As you mentioned, botulinum toxin for people with focal TD, and we use that to treat it. We may reduce the AIM score significantly. They may have, one specific issue where it's eye closing issues or jaw closing issues, and we'll inject botulinum toxin for those individuals. We've also had individuals that may have mixed movement disorders, and that may require more nuanced management, and we can talk about that another time. For people that get mixed movement disorders, or how to manage individuals that develop TD and then are on treatment and then develop tremor. And these are other topics to talk about. But at the same time, we also have deep brain stimulation for individuals. I speak as a movement disorders neurologist. We've had quite a few individuals get it for refractory tardive dyskinesia that is very severe. And now we actually end up coming back the other way. We've had DBS and we've used it. And DBS is actually more data has emerged. So it's moved up the chain in terms of level evidence. But at the same time, we may use that in combination with VMAT2s. And that, I think, allows for phenomenal collaboration like this program, which is between neurology and psychiatry. And I think that really allows for great collaboration between two fields.
I completely agree. And I have certainly enjoyed collaborating with you and speaking with you, both now on the podcast, and we have co-presented at NEI meetings, and I've enjoyed that greatly. Well, I want to thank you, the audience, for listening. I hope you found this informative and enjoyable. And for more podcast offerings, for more of our NEI offerings, you can certainly go to our website, which is neiglobal.com. And you can find NEI podcasts wherever you get your podcasts. NEI Psychopharm is one way to find it, or you can certainly search my name as the moderator of most of these podcasts. I want to thank you so much for your time and wish you good luck with your patients and your clinical work. And Laxman, thank you so much for your time.
Thank you very much. It was a pleasure being here.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.